So this is a topic in which I'm definitely no expert, but it's something I've had an interest in. And over the quarantine period, I did some reading and I put together some information. So that's just what I'm going to be sharing here. So I want to start off talking about just some anatomy as it relates to occlusion. So let's start off with some just really simple stuff. This is just a skull with the maxilla and the mandible. And some of the relevant anatomy here is there's this glenoid fossa, which just is a depression in this zygomatic process of the temporal bone. So when we talk about coronoid or glenoid fossa, it's just this depression right here. And then if we think about the mandible, there's some, there's those two little pointy parts of the mandible. There's this one, which is the condyle, and then this one over here, which is the coronoid process. Basic, right? So with that, let's go and talk about some of the muscles that are relevant. So when I think about the muscles, I think about there's the muscles that are used for closing the mouth and the muscles that are used for opening the mouth. They always talk about four main muscles of mastication. That I'm going to point out, I guess, the fifth one. But when we talk about closing, there's three that are involved, mainly involved with closing. So we have the temporalis, which is right up here, which is connected to the coronoid process. And then we have the masseter and the medial pterygoid, which kind of form this sling around the ramus of the mandible here. So on the outside, we have the masseter muscle. And then if you flip the mandible over, on the inside is the medial pterygoid muscle. And so both of those, all three of these muscles all help to close the mouth. So they kind of, the mandible is rotating about this axis here of the condyle, and the masseter and the medial pterygoid pull it up here, and the temporalis pulls it up through the coronoid process here. And then how do we open the mouth? This is the one I think is a little bit, less obvious. So in order to open the mouth, we can pull it down from about the chin. You got this little bone down there, that hyoid bone. And so there's a couple muscles, but there's the main one I think that people talk about is the mylohyoid muscle, which goes from down at the bottom of the chin to this little hyoid bone. And the other one that is kind of a little less obvious, again, is this lateral pterygoid. So if you think about the lateral pterygoid, has got kind of two little bellies on it. It's got the superior and inferior bellies of the lateral pterygoid. We'll talk about those more in a second when we talk about the joint. Actually, they're both, the superior one is connected to the condyle and to the disc, and the inferior one is connected to the condyle. And when they contract, they're actually pulling the mandible forward. And since there's this, in the glenoid fossa here, there's this ramp here called articular eminence. When you pull the mandible forward, it kind of slides down this ramp, and that opens and pushes the mandible forward. So when we press play here, you'll see it kind of pulls it down this ramp, and then also this mylohyoid is pulling the kind of the chin back and opening your mouth. So those are the what I consider to be the muscles of mastication, first for closing, then for opening. All right, now let's take a look inside of the joint. So this is a very simplified version of the joint, mostly for us to be talking about some of the movements in occlusion. So again, here is that glenoid fossa. So this is all part of the zygomatic process of the temporal bone. This here is the articular eminence right here. And so, you know, I've kind of really simplified the joints into having this tissue back here, which is retrodiscal tissue. It's innervated, so that means it's got nerves and it's got blood supply. Then we have the articular disc, and I'm not talking about all the capsules and all that kind of stuff. I'm just going to simplify it, just call this the disc, which is supposed to be in between the uh, the glenoid fossa here and the condyle of the mandible. So the disc is in between the two, and it's a non-innervated tissue, so that you don't have feeling in your disc. And then, like I said before, we've got these muscles here. We've got a superior belly of the lateral pterygoid, which is connected to the disc and to the condyle. And then we have the inferior belly of the lateral pterygoid, which is just connected to the lateral pterygoid. I mean, just connected to the condyle. And again, when you open your mouth, you know, there's a little bit of debate about how these motions actually occur, but I think probably the most widely used is that, or widely accepted, but would be that at first the mandible starts to rotate. So it rotates in this, in the glenoid fossa, and then it gets pulled forward down the articular eminence here. So the articular eminence is just this ramp part of the glenoid fossa. And, you know, with those, remember we talked about the muscles of opening. So partially by this lateral pterygoid contracting, and then also the mylohyoid pulling back, you can open up the mouth, and the condyle slides down the articular eminence with this disc in between it. And so those are some of the relevant anatomy of occlusion. And so the next thing I'm going to be talking to you about are some concepts related to occlusion. And there's a couple of things that I've come to realize about occlusion over the course of the last, I don't know, 10 years since I've graduated from, or since being in dental school and graduating from dental school. So, you know, I think it's particularly difficult to teach occlusion in dental school, as I've come to realize. And I think that's for two reasons. Like one, there's just so many different philosophies related to occlusion. So it's, you know, difficult. I'm sure that different faculty members are all going to have different opinions as to, you know, what is the best philosophy in occlusion. And two, it's also difficult to teach occlusion to people that haven't seen a lot of teeth. So as a dental student in a D2, D3, or even a D4, if you haven't seen a lot of teeth and a lot of patients and seen how patients' teeth fit together, it's hard to kind of, you know, some of these concepts don't always make as much sense until you've seen different kinds of patients. And so I think that, you know, if occlusion is an area that you're interested, if you're interested in doing either bigger cases or just making sure that when you're doing restorations that you're, you know, aware of what a patient's occlusion is, or if you have patients that come in with joint problems and it's something that you want to learn more about, you know, as someone that, like me, that is a general dentist that, you know, didn't go through a residency program, many of us will end up going to one of these centers to learn more about occlusion. So like, Coyce and Spear are two of the really big ones right now. They both have occlusion classes. They're 3 or 4 day classes. They're, you know, relatively expensive. So I had always, they're not courses I have taken, at least not yet. Of course, Dawson, who's kind of, you know, one of the modern day gurus, or one of the, I guess, modern gurus of occlusion, or he was. He's had an academy, and they continue to run this academy, and they've got multiple steps in their occlusion courses. So what I want to do today is obviously can't go to the level of any of these courses, but just give some ideas based on what is being taught in these courses. So most of the courses, between Coyce and Spear and then obviously Dawson, are based on some of Dawson's philosophy and his textbook related to occlusion. And so I'm just going to pick that one kind of philosophy and give a little bit of overview of that particular philosophy. So again, there's going to be other different thoughts related to occlusion. This is one that's become pretty popular. A lot of my contemporaries have taken classes from Coyce or Spear or Dawson, and so I want to explain what, as I've come to know, some of their philosophies related to occlusion. So here we go. So, the Dawson Academy puts it out as Dawson's 5 basic principles. And so you could read these principles, and I'm going to go through these principles, but in order to understand them, you have to kind of understand what the words inside of the principles mean. So I'll go through them one by one. So the first principle is that you're supposed to have stable contacts on all teeth of equal intensity when a patient is in centric relation. So in order for that to happen, you have to have an idea of what do they mean by centric relation. And this is probably one of the more controversial aspects of occlusion. So, but I'm going to tell you the Dawson philosophy related to centric relation, and they describe it as the most anterior, superior, medial position of the condyle disc assembly within the glenoid fossa. So just for reference, that's superior, anterior, and medial. And we've already kind of talked about where the condyle is and what the glenoid fossa is. But, for me, two things I want to talk about. First of all, when they talk about anterior, superior, and medial, that is definitely a Dawson concept. There's other definitions that were superior and posterior, and I know that was something that, if Dawson's philosophy was that you're not supposed to jam the mandible back posteriorly, his philosophy was superior and anterior. And I don't know enough about the reasoning for that to explain that, but just to say that that's the Dawson philosophy, anterior and superior. But one thing that when I first heard that definition, it kind of was hard for me to understand, because if we're looking at this shape of a glenoid fossa, it's this curvature, it's kind of with this ramp. It's like, what, here would be the most superior point. Here's the most anterior point. Where is it supposed to be within that? Where is it supposed to contact? It seems like it could contact anywhere within this range of points here, because it's not like this is if this was a box, we would know the most superior and anterior point would be right here. So the way that they describe getting someone into the most superior and anterior position, and this is where the Dawson philosophy can kind of vary from the way it's taught by Spear and Coyce, as I understand it. They don't necessarily teach this, but this was part of the original Dawson philosophy, was in order to get the patient's mandible, or that condyle disc assembly, into the most superior and most anterior position, is to do something called bilateral manipulation, where you take your thumbs and put them on the front of the patient's mandible and then your fingers on the posterior part of the mandible, and you manipulate the mandible by kind of rotating it into that position in something they call bimanual manipulation. So that's their definition of centric relation. And just one point is that centric relation is a relationship. It's kind of a relationship between the maxilla and the mandible, as kind of defined as this relationship between the condyle and the disc related to the glenoid fossa. So it's kind of a joint thing, as opposed to centric occlusion, which is just the position of the teeth when the joints in CR. So centric occlusion is a tooth thing, is an occlusion thing. Centric relation is a joint thing. All right, and so once those, assuming that the joint is in CR, the teeth should fit together, and it says a stable contacts. Where should those contacts be? And I think Dr. Robles actually has a coffee cup with this picture on it. This is the famous Dawson kind of picture that shows the contact points of the maxillary and mandibular teeth. So if we're talking about maxillary anterior teeth, the contacts would be somewhere right above the cingulum. So the dots are the contact points when the patient is in centric occlusion. For the mandibular incisors, of course, they're going to be hitting the maxillary incisors on their incisal edges here for the mandibular incisors. For posterior teeth, so the posterior teeth are going to contact on their marginal ridges and central fossas for both mandibular and mandibular and the maxillary teeth. And then also they're going to contact on their functional cusp. So the functional cusp, if you think of the way that teeth fit together, for the maxillary teeth, they're on palatal cusps, and for mandibular teeth, they're on the buccal cusps. So these buccal cusps of the mandibular teeth are going to be contacting the marginal ridges and the central fossas of the maxillary teeth, and of course the palatal cusps of the maxillary teeth are going to be contacting the central fossa and marginal ridges of the mandibular teeth. So that's where the contacts belong. So there shouldn't be contacts on cusp inclines. They should just be on these marginal ridges, central fossa, and kind of the cusps of those functional cusps. There's one variation. This is kind of like a pro tip, something that I had to read further to kind of understand, is this idea of long centric, which basically means those points I just showed you where the teeth are supposed to contact when the patient's in centric occlusion. So when the joint's in CR, the teeth are in centric occlusion. There's a little bit of variation where the anterior teeth are going to contact, depending if the patient is laying down or if the patient sits up. So the patient's laying down, the contact might be here. When the patient sits up, sometimes the just postural position of the head will change the contacts of the anterior teeth, so that the mandibular incisors will be a little bit contacting the maxillary incisors a little bit anteriorly of where it was when the patient was laying down. And that's called long centric. So that's why sometimes if you check your patient's bite laying down versus sitting up, it can be slightly different. All right, let's go on to Dawson's second principle, and that is that anterior guidance is in harmony with the envelope of function. So what does that mean? So again, anterior guidance just means how your front teeth guide the movement of your mandible when they contact, and so it's kind of the contact between your the incisal edge of your mandibular incisors and the linguals of your maxillary incisors. And when they talk about the anterior guidance should be in harmony with the envelope of function, they also sometimes call this outside in movement, which means that when it really has to do kind of with the closing of your teeth. So when you function, your teeth are in this thing called the envelope of function. So when you chew up and down, your mandible relative to your maxilla moves in this envelope, which I'm sure you've seen before. But the important part of this with the second principle is predominantly with kind of the closing movement, where your mandible actually is a little bit protruded before it closes down. So it's coming from outside your mouth to inside your mouth. That's what they call outside to inside movement. And I'll just read this here. It says that maxillary anterior teeth should be inclined or contoured, so that this lingual surface of the maxillary anterior teeth should be inclined or contoured so that when performing functional movements, so closing your mouth through biting or chewing, the path of this mandible does not lead to the mandibular incisors bumping into the lingual contact of the maxillary incisor. So I'm going to play a little animation here. So as your mandible closing, you don't want this to happen. You don't want this mandibular incisor to contact the lingual of the maxillary incisor, prior to closing all the way. So in this particular case, if this part of the tooth wasn't adjusted, when the patient would bite or chew, they could chip this incisal edge of the maxillary incisor. So what you do is you would adjust the contour of this, of that inside, or that surface here of the lingual surface of that maxillary anterior incisor. So, well, you could check this practically, but articulating paper in the patient's mouth and have them chew and see if there are contacts that are ahead of the centric contact, which would be right about here. So if when the patient bites or chews, you've got contacts here, then you'd adjust them so that you get your contact here. All right, the next concept is that the posterior teeth disclude during mandibular protrusive movements. Protrusion is just this, sliding forward. And so this is kind of related to the previous point. And this is just the opposite movement. They call this inside out movement. So when your teeth are together and then you're sliding forward. And in that case, we want your incisors, the lingual surface of your maxillary incisors, to keep your posterior teeth separated. So you want, I'll just read it again, the anterior teeth keep the posterior teeth separated everywhere aside from when all the teeth are touching in centric occlusion. So we want it so that when you slide forward, your anterior teeth keep your posterior teeth separated. And that's something I didn't really understand, I don't think, when, until I started looking into this topic, is that really the only time that your posterior teeth should be touching is in centric occlusion. So when assuming that you have canine guidance, good anterior guidance, you should be able to go into protrusive, and only your anterior teeth are going to be touching. Your canines, your lateral incisors, and your central incisors would be touching when you go into protrusion. And again, they call this inside out movement. And then the last 2 points are kind of related, is that what your posterior teeth should disclude during lateral working and non-working movements. And so this means when you bite together and you slide left to right on your canines, or just in any way when you slide left to right, only your anterior teeth should be touching and your posterior teeth should not be touching. Again, I don't think I realized this when I was, prior to looking into this, that when, a patient bites together, or if you're checking occlusion on a posterior molar, when the patient slides left and right, they shouldn't be sliding on the cusps of those posterior teeth. They should only be sliding on their anterior teeth. So again, if you're thinking about your mandible here, Just to give you an idea, I've heard some people had some issues with this concept of working versus non-working side. So if you slide your mandible to the left, and I've kind of positioned this picture so that you could be sitting here and looking at the screen. This would be sliding this mandible to your left would be just like you moving your jaw to the left. Then if you slide the mandible to the left, then the left side is the working side of your mouth. And so all the teeth on the left side, both the mandibular left side of your mouth and the maxillary left side of your mouth, that's now the working side, because that's the side you slid your mandible to. So on that working side, you shouldn't have any contacts on your posterior teeth as you slide your mandible to the left to the working side. And then also when you slide your mandible to the right side, you shouldn't have any contacts on any of the posterior teeth either. So those would be your I need to change this. It should say non-working contacts over here. So you shouldn't have any non-working contacts or working contacts. So as you slide your mandible to the left and the right on your posterior teeth, you should not be having any contacts. And that's where they get this expression, dots in the back, lines in the front. So that just means that when you bite together, you should have contacts on your posterior teeth. You have contacts you'll have these little dots on the anterior teeth too, but when you slide side to side, you should only have these lines on your front teeth. So only your front teeth are touching when you go into protrusive movements, and then also into lateral intrusive movements when you slide side to side. So that's dots in the back, lines in the front. And there's this, again, this is another kind of pro tip. As you slide side to side on your canines, most people don't go past their canines. They only slide until their cusps kind of touch, and that would be it. There's some people that can experience something called crossover wear, where they slide on the canines and they keep on going. Oh, it kind of hurts my teeth to do that. So that would be sliding on your canines. This is where most people go, and they just keep on going. And then so they can cause some wear of the anterior teeth when this would be the left side of their left mandibular incisors start to wear the right maxillary incisors, and they can do it on the other side. And sometimes if they do that, they get what they call the chevron wear appearance, where they've kind of worn their maxillary anterior teeth in this weird shape, and you can try to have them see if they slide past their canines to try to diagnose that. All right, so we just talked about like a patient, how they should be ideally. Ideally, their joint should be in CR. And when their teeth fit together all the way, in that we call maximum intercuspation, when all the teeth are as best interdigitated as they can be. That should be the same position as centric occlusion, because that means that their joint would be in CR when all their teeth interdigitate. But that doesn't always happen, and then also sometimes that can cause sometimes the patients to have soreness in their joint or a lot of wear. So if somebody's got signs of joint instability or even occlusal instability, so a lot of wear or pain in their joint, in order to treat that, I talk about determining, is the source of their problems, is the source of their pain muscle related, or is it joint related? So we'll talk about those two things. We'll start off talking a little bit about the muscles as to why what could happen with the muscles having pain. So if a patient has it so that when they bite together, when they're, let's say their joint is fully seated here, but when they try to bite together, their teeth are aligned in such a way that they won't interdigitate with the joint being in its best position. We've got a little bit of a interference here. And so what the patient may do, not intentionally, but just physiologically this may happen is that they may try to slide their jaw forward and find a position at which their teeth can fit together in a good position. And so they've pulled their jaw forward, they've slid it down the condyle down this articular eminence and pulled it forward. And then now they found this position where their teeth can fit together. But all of this position may allow their teeth to come into maximum intercuspation. As it's pulling the jaw forward, this muscle right here, which is pulling the jaw forward, the lateral pterygoid, can start to become, it can start to hurt because it's working all the time to pull their mandible forward. And then, maybe some of these other muscles are somehow contributing as well. So in order to keep the jaw in this position, which it might not want to be in, it can put pain on the patient's muscles. And in order to help with this, and also in order to diagnose to see if this is the problem, you can use something called a Lucia jig. So I'd never seen one of these again until a year or two ago. But so a Lucia jig, all it is a little piece of plastic that can go on their maxillary incisors and prevent their posterior teeth from touching, really any of their teeth from touching, so that once you put this into the patient's mouth, then they can close and let their joint go into its best position without having to worry about where the teeth are. So the patient can maybe go and now slide back into a good position, and they call that process of allowing the muscles to find a stable joint position without the interference of the teeth, they call that deprogramming. So you can put this Lucia jig in there and wait for 15 minutes and then see if the patient finds them, if that gives the patient some relief and they can find a different joint position. You can actually mark where the teeth are touching initially and then give it to them 15 minutes later and then see where the mandibular teeth are touching this Lucia jig, and that'll tell you if the teeth have moved relative to each other. Sometimes this has to be, you give someone something called a deprogrammer, which is just kind of like a Lucia jig that they wear for an extended period of time, for a couple of days or a couple of weeks, so that they can find this joint position. So that's a process called deprogramming, allowing the patient to find a better position for the joint by not allowing the teeth to contact and the muscles to put it in the right place. This is what a Lucia jig looks like. You can just fill this up with green stick compound or with PVS impression material, and then have the patient, bite into it, and then their mandibular incisors are just contacting this flat plane. So, that way the patient's closing without having to worry about where the teeth interdigitate. All right, let's talk about now, what if there's a joint issue? So, there's some joint issues which I'm not going to talk as much about. I mean, like osteoarthritis, where this condyle can start to degrade, I guess, and so that would you'd hear maybe some creeping noises as it's rubbing against the opposing bone, or even maybe against the disc. But what I'm going to talk about two kind of disorders with the disc that we hear about a lot, and those are the displaced discs. So you can see in this picture here, this disc was supposed to be back here in between the glenoid fossa and the condyle, but it's not. So there's two different types of displaced disc. There's a displaced disc that when the patient starts to open, even though it started off displaced, it will eventually find its way back into the disc as it starts to translate down the articular eminence. It finds its way into the disc, and then it can complete opening with the disc in between. And so when it pops back into the disc, it's called reduction. So if you have disc displacement with reduction, that means that the condyle found its way back into the disc, and that's what you hear when you hear people open up their jaw and it goes pop. It finds its way back into the disc. Sometimes, though, when the patient opens, it doesn't ever find its way back into the disc. So it does not reduce back into the disc. And this is called disc displacement without reduction. And so you can imagine if it never finds its way back into the disc, one symptom that you would see would be limited opening, because the patients, they've got the disc here preventing them from the condyle rotating all the way or translating all the way. One thing to note is if you've got disc displacement with or without reduction, if it's only on one side, so then that would be the side where the patient has an issue and can't open all the way, and so they would start to if you can imagine, this is the side, I don't know, I know this thing mirrors the video, but if it's on this side of my mouth and this is the side where I have an issue and I can't open all the way, then I start deviating towards that same side. Anyhow, one of the things when you have a disc displacement is that what will happen is you're riding on this retrodiscal tissue instead of riding on this disc. And so remember, this disc is innervated. I mean, the retrodiscal tissue is innervated, the disc is not innervated. So that can cause pain by riding on this disc. That's why people sometimes will have disc displacement, can have pain, because it's really pain from this retrodiscal tissue becoming irritated from having, the acting as like a disc when it's not supposed to. So the last slide I want to leave with is just the slide to, what can we do if we've got some of these issues where the joint is in pain. So you can treat them slightly differently depending upon, again, whether it's the muscles that are causing the pain or if it's an issue with the joint. So again, if it's the muscles causing the pain, what you can do, you could start off with trying to just do a lucia jig and deprogram the patient so that you find out maybe the position in which the joint is stable is not the same as maximum intercuspation. And if you can find that out, maybe you can do it quickly with the lucia jig, maybe you have to do it with the deprogrammer over a longer period of time. Once you do that, then really the ultimate treatment is to get the teeth in the correct position so that MI, maximum intercuspation, would be the same as centric occlusion. And for me, it took me a while to realize that means that you've got to make some changes on the teeth. So you could try to do what they call occlusal equilibration, where they just grind on the teeth to get the contacts to be right. You could do orthodontics. And then sometimes you have to do things that are more extreme, like you might have to do full arch restorations in order to change the occlusion of the patients, or maybe sometimes it might be a bone issue and you've got to do orthognathic surgery in order to get the teeth lined up correctly. So those are, some long-term solutions. Maybe an interim solution would be to use some type of bite splint, which would allow the patient only to be contacting on their front teeth so their back teeth can't contact, so their joint can go back into a good position. So there's a splint called a dual arch B splint. That's the one that the Dawson recommended splint for muscle pain. And this only allows contact in the front teeth so that the back teeth aren't, putting the mandible in a bad position. One thing that's different about this than like a deprogrammer, so a deprogrammer is basically just the long-term lucia jig. It just goes on the front teeth. This covers the front teeth. It's got this little ramp in the front and a little bump in the bottom to keep the back teeth separated, but it covers all of the teeth. It's something they wear on both arches, and it covers all of the teeth. And the reason that they do that is because if you wear a deprogrammer or a lucia jig and you're only contacting on your front teeth and you wear that for too long, if your back teeth don't have anything, if they're not touching, they can start to super erupt and you can mess up the patient's bite because you've got these posterior teeth super erupting while the front teeth aren't. And so then now you've created a little bit of an open bite there. So that's why this dual arch B-splint comes in. If it's just a joint problem, you wouldn't want to use this dual arch splint because then it's you're not treating an issue. It's the dual arch splint is for allowing the mandible to go back into a correct position. If it's a joint issue, what you want to do is you want to get this joint or this retrodiscal tissue, which the joint is now riding on, to kind of give it a chance to give it some healing. You might not be able to get the disc back into the correct position, but what they say you can do is get this retrodiscal tissue so it's not so inflamed, and it's sometimes going to even form a little bit of a pseudo disc if that tissue isn't so if it's less inflamed essentially. And for that they use something called a superior repositioning splint. So this is a splint which covers again all of the one arch, and it has contacts for all of the posterior teeth. And really, essentially all it's doing is it just gives this patient a nice kind of flat plane to grind on, so that if there were any kind of interferences on that patient's teeth that were putting extra stress on this joint, that they'd be eliminated. And that will just give this tissue back here some time to heal and maybe form that pseudo disc. And also they're going to provide anterior guidance into the splint just to replicate where the patient should be having anterior guidance. And it's just kind of the splint, because it just helps the patient, so if there were again any interferences that weren't supposed to be there, if they were there, they would put extra load onto the joint. They're going to be taken away by using this superior repositioning splint. So with that, that's my little deep dive or shallow dive, however you want to look at it, into some different concepts in occlusion. So I hope you enjoyed. How do I stop this?